in education and training in infection control and promoting CIC certification, guiding IPs to build successful IPC programs and design training programs as per the customer requirements and promote collaborative work with institutions interested in providing training and scientific events. Now I'm privileged to introduce today's speaker, whose name is Ms. Lakshmi. So Ms. Lakshmi, she is an accomplished infection control practitioner with over 4 years of experience in this field. She started her career as a link infection control nurse, serving as a liaison between healthcare facilities and the infection control department to help in identify and prevent the spread of infection, and progressed to be a full-time infection control practitioner, where she now oversees the development and implementation of comprehensive infection control programs. She is a certified infection control practitioner, a testament to her expertise and commitment to providing safe and effective infection control practices. She is currently pursuing her master's degree in infection control to further expand her knowledge and skills in this field. She has 14 years of nursing experience in a variety of settings, including intensive care units, trauma surgery centers, and long-term care. This background has equipped her with a deep understanding of the complexities of patient care and the critical role that infection control plays in ensuring patient safety. Throughout her career, Ms. Lakshmi has been recognized for her dedication, leadership, and innovative approach towards infection control. She has contributed significantly to improve the quality of patient care, reducing infection rates, and educating healthcare providers on the latest infection control practices. Ms. Lakshmi, now over to you.
Thank you so much, Anu. Am I audible?
Yes, Ms. Lakshmi, you are audible.
Okay. Thank you so much for that wonderful introduction, and thank you also for the IPQ Academy, and especially our participants for joining during their weekends. And it shows how much commitment and passionate you are in infection control and learning and updating your knowledges. It's really very good. Okay, moving on to today's topic. Today we are going to discuss about aspergillosis. So in today's session, in today's sessions, we will be discussing about. Hello. Okay, in today's sessions, we'll be discussing about aspergillus, its cell structure, the method of reproduction, replication, nutritional growth requirements, the predisposing factors to infections, etiology, pathogenesis and laboratory diagnosis, management strategies for patient care and effective prevention and transmission, current global impact and challenges with this aspergillus, and also our infection control measures and infection control risk assessments. So what is aspergillus? Aspergillus is a saprotrophic fungus. It is a filamentous mold. It is often called as black mold. Saprotrophic, that is, it can feed on all organic matters and survive. And it is ubiquitous in nature, like it is present in soil, plant, organic matters, dead, decayed substances. So it's basically present everywhere around us, and it is a spore-forming fungus. Although there are several species of aspergillus, 4 important pathogenically significant species are Aspergillus fumigatus, Aspergillus flavus, Aspergillus niger, and Aspergillus terreus. Among these 4, Aspergillus fumigatus is most prominent in causing human infections. So how does this aspergillus grow in soil, in plant, and in human body, in host? So we need to know the nutritional and growth requirements of these species. So this aspergillus can grow in extreme temperature from 25 to 37 degrees and extreme pH. And it is also globally distributed. There is no defined geographical area for this organism. It is present everywhere. And it has an excellent metabolic and stress response. So for it to grow efficiently, it needs nitrogen and carbon cycle, but it can survive, it can starve without nitrogen and carbon cycle. And when a favorable condition occurs, it can grow into an infective organism. Also, It can adapt to hypoxic conditions, and it is very good in getting their cations. Iron, zinc, and calcium is very much essential for the growth of Aspergillus, but getting iron from a human host that it is already binded with a heme protein, it's complicated, it's challenging for these organisms, but it has its own mechanism of releasing several chemicals, several transporters to acquire the needed cations from our body. And also, this has unique cell walls, like it has cell wall, different cell wall when it is a spore, and it has different cell wall when it is already germinated, which we will be discussing in the upcoming slides. So how does it reproduce? What is the what is the cycle of reproduction? So it can even reproduce through an asexual cycle as well as sexual cycle, and both of these can go into a vegetative growth. So for an asexual cycle, there is a conidio, we call it as conidia. So in a conidia, there is a conidiophore. The stem is what is called as conidiophore. And in that, the conidias, the smallest conidias is arranging in a linear fashions. And once it gets matured, it can easily disperse into the air, and it can cause infections when inhaled. This conidia is only 2 to 3 micron in size. It is very small, and it is easily carried by air to distant locations. Sexual cycles are not very common. Most common reproductive cycle is asexual cycle, but sexual cycle also occurs when two opposite strains meet and mate. And when they do that, there is an enclosed structure that forms, and all the spores are contained in that. So we call that as cleistothecia. So there is still difference in this conidia and ascospores. In conidia can start to germinate when it is already 37 degrees, but ascospores will germinate only after it reached 65, after the temperature reached 65 degrees Celsius. So an infection with an ascospore is less common than an infection with a conidio. And when these two spores found a stable medium or stable ground, for example, plant or soil or decayed matters or a human host, they tend to change their cell structure and form hyphae. Through this hyphae, they get attached to the human cells, and then they invade the human host cells. So, like I said, the cell wall of this Aspergillus is different when it is a conidia, and it is different when it is a hyphae. So this is the structure of the cell wall of the conidia. You can see that there are two layers called rodlets and melanin. This is not, the rodlet layer is not present in hyphal stage. So what does this rodlets do? So this rodlets helps in conidial dispersion. This is also protecting it against dehydration, and also it prevents the host cells to recognize this. And this is also one of the reasons that we cannot contain this, or our immune system cannot engulf it due to the phagocytosis. And also this melanin layer is protecting against the UV radiation. This also helps in masking our immune response, and also it inhibits the phagocytosis. And other structures like galactomannan, chitin, beta-glucan, alpha-glucan, and protein are present. And some of these proteins helps us in diagnosing this Aspergillus species. Looking at the cell wall of hyphae, as I mentioned earlier, you can see that there is no rodlets, and even the melanin layer is very irregular. This helps in addition to the surfaces, and thereby it extends its hyphae and get attached to the host cells. So the pathogenesis is like this. So once they germinate, they go into hyphal extension, and then tissue invasion and destruction occurs. This is the slide that is from a laboratory. As you can see, in the 0 hour, it was a conidial spore, and then it germinates, and then by sixth hour, almost all the spores are started having hyphae. So this is how it germinates and invades our tissues. So now, activity for us. So now that we know Aspergillus is a fungal infection and it has its own unique characteristics, what do you think about this? Aspergillosis is a primary infection or a secondary infection or an opportunistic infection? Please give your answers in the comment box. We can just pause 30 seconds for this. Okay, excellent. Okay, excellent. Yes. As you all gave answers, this is an opportunistic infection. This is not a primary infection. That is one thing that is good about this species. So moving on. We will see what are all the predisposing factors. So we now know that this is an opportunistic infection. So all those members who inhaled this spores is not getting infection because of our effective mucociliary clearance. We clear this organism through cough, through sneeze, and it gets out of the body, and the remaining that is inhaled is taken care by our immunity and immune cells. But for patients who are having neutropenia, 500 cells per cubic millimeter for more than 10 days, anyone who underwent solid organ transplantation or on corticosteroid therapy, any hematological malignancies, chemotherapy patients, chronic granulomatous diseases, and patients who had hematopoietic stem cell transplantation, these are all very high risk categories and they can easily acquire these spores and they can develop infections. So we also need to know how the spectrum of Aspergillus is. So when it enters a normal host, due to effective clearance, infection is not occurring. But if it goes into an immunocompromised patients, invasive aspergillosis occurs. If it is on a cavitary lung disease patient, aspergilloma is formed. If it is on a chronic lung disease with mild immunocompromised state, chronic pulmonary aspergillosis happens, or sometimes chronic necrotizing pulmonary aspergillosis happens. Patients with asthma, they also have acute bronchopulmonary aspergillosis and also severe asthma with fungal sensitization. So it causes different infections to different in a different spectrum due to their predisposing factors. So what is the clinical manifestation? So they manifest, the patients do not manifest any specific signs. Most of the signs and symptoms are very general, like variable intensity of fever. In the initial stage, we can see that fever is resistant to antibiotics, but oftentimes fungal infections are actually kept behind when they are diagnosing infections. It's always thought bacterial, and cough is there, excessive sputum protection, pleuritic chest pain, pleuritic rub, bronchospasm, hemoptysis, plague-like lesions, mucosal necrosis of the lower airway. So as you can see, all these signs and symptoms are very common with other lung diseases. So we cannot really diagnose Aspergillus that easily. But we do use a combination of approaches. Of course, histopathological investigation from a lung biopsy is the gold standard to investigate this, but additional diagnosis like a ball culture and then antigen detection of the galactoman, and this is the one of the cell wall component of Aspergillus. So there is antigen detection, also beta-D-glucan. This is also a cell wall component. PCR or DNA sequencing also helps. Lateral flow assay with glycoprotein of Aspergillus, and also radiological investigations such as chest X-ray and HRCT. So all these other investigation except histopathological investigation suggest that it is an aspergillosis, but they cannot confirm. And this is one of the challenge with Aspergillus, finding out Aspergillus. So standardized diagnostic criteria for invasive aspergillosis was developed, and and it is based on multiple factors. So if your host is immunocompromised with neutropenia or HSCT, corticosteroid or immunosuppressant therapy, along with nodular lesion or air crescent sign or cavity in the lungs, we may say that it is probable invasive aspergillosis. If the patient has a culture, galactose and an antigen, beta-D glucagon, this also cannot confirm the diagnosis. If these three are present, we can say it could be possible invasive aspergillosis. When histopathologically it is diagnosed, that is when we call it as proven invasive aspergillosis. Treatment, of course, with an antifungal therapy, azoles, echinocandins, amphotericin B, lipid formulations of amphotericin B are prescribed. Sometimes it is given as a monotherapy or combination of therapy is used. And also they do immunomodular therapy for these kind of patients. So what is the, hello? Okay, so what is the impact of this aspergillosis? As we already discussed, it is an opportunistic infection. So what happened when we all had big pandemic? What happened with COVID? So there is COVID associated pulmonary aspergillosis, and in severe COVID cases, this invasive pulmonary aspergillosis varied from 19.6 to 33.3%, and it also increased the mortality between 16 to 25% in patients with co-infections. As you all know, data collection, data validation, everything is compromised during this pandemic. But with the available data itself, it can say that there was some very high magnitude of co-infections that occurs due to the aspergillus. And this is also due to prolonged ventilation, steroid and immunotherapy that was given during COVID. And also more research is needed to find out the magnitude of these co-infections. And of course, mitigation should be the focus in all the hospital settings. Having said that, so as an IP, in which circumstances do you think consider the possibility of aspergillosis? Is it prior to the surgery or during patient admission, during a construction and renovation, or upon admission to the ICU? Please give your answers in the comments. Excellent, yes. So an IP has to think about aspergillus infections when a construction a project or renovation project is proposed to our stakeholders. So what should the IPs do during construction and renovation? The IPs, first of all, has to be notified. This is one of the things commonly missed when they are designing, when they are in the designing phase or renovation phase. They contact the facilities, the stakeholders are aware, but they are not much aware of the risk that is involved with not involving an IP. So an IP has to clearly communicate in the meetings, or she has to be a part of the meeting during design phase and renovation phase. And she has to conduct a thorough infection control risk assessment, and we can give recommendation on focused preventive efforts. This is based on the impact that is assessed with the adjacent units. And once all these recommendations are given, of course, we have to do continuous surveillance of the hospital epidemiology, and frequent visits to the construction site has to be done to assess whether our recommendations are followed, whether staffs are compliant to all the recommendations that we provided, and all those things has to be documented and reported to the stakeholders. So how do we know? How do we know which unit is at risk, which unit is not? How do we know the impact of certain construction? So there are several ways that we can find out this the risk. First is based on the type of construction, whether this is type A, B, C, or D. Type A is small projects with no expected dust. Type B is small scale, short duration, minimal dust generating constructions. Type C is longer duration, and it will also generate moderate dust. type D is major demolition and renovation. And also, we also have to look at the areas that are at a different level of risk from low to highest. So office areas are at low risk, mostly normal individuals with good immune system, with healthy individuals will be present in the office areas. Whereas cardiology, echocardiography, endoscopy, nuclear medicines, physiotherapy, respiratory therapy, radiology, and MRI, they have moderate risk. That's the category. And then CCUs, emergency, labor and delivery, your laboratories, newborn units, nursery and pediatric units, OPD surgeries, surgical units, they all have highest risk during this construction and renovation. And highest risk areas are any unit that has immunocompromised patients, like your CCU, ICU, CSSD units, negative pressure isolation rooms, oncology, OT, and cath labs. So based on the type of construction and the risk area, our mitigation measures has to be recommended. So what will be our recommendation? Since we cannot stop or prevent dispersal of this Aspergillus species, so our main focus is mostly containing it in the construction unit itself, preserving the air quality, removing the high-risk patients from that areas. So that will be our main focus. So how do you contain? There are containment barriers, as you can see in this picture. Sometimes there are dry walls. Sometimes the construction unit uses plastic sheeting like this. But we need to be very, very careful when we're using these barriers. We need to see that there is no opening, it's not tampered. Sometimes we fix everything at the start of the construction, but the workers that is working there is not aware of why we are doing this. So they may come out, go in, they tamper it, they tear it. So all those things has to be supervised every day. That's one of the biggest role of IPs during any construction process. And also we can redirect the traffic if construction is happening in like entrance. You can have another entrance, have signs that says clearly where to go, people assigned there to tell them where to go, redirecting the traffic flow. And also whatever risk or whatever recommendation that you can give, you can put it as a poster outside the construction units for people to read it. They should be clearly stated and displayed for visitors and others to know that these are the recommendations. And also we have to, so mostly the air quality is what we are focusing here. So we have to isolate the ventilation system. We have to close the ducts. As you can see in this picture, you can use materials to close the ducts from mixing in the patient area. And also negative pressure has to be created. This can be easily done with an exhaust fan and a portable HEPA filter and portable containment, like in this picture. If this is a small project in the middle of the patient unit, then we can use portable containment unit like this to contain the dust. And also while removing the dust, we can also use HEPA filtered vacuum cleaners to remove it instead of a normal vacuum cleaner. And there has to be a process like every day, end of the construction, all the dust has to be removed from that construction area and it has to be discarded elsewhere. So these are all the infection control risk mitigations that we have to convey to our stakeholders. So that's this about the Aspergillus. We can discuss some CIC questions. Those for this will be helpful for those who are preparing for CIC. So our first question is, so the IP hears that one of the nursing unit in this facility will soon be renovated. After verifying the information, he contacts the newly hired director of design and construction to explain how important it is for the IP to be included in the planning and design of all renovation projects. Which of the following is the most compelling argument? So the IP supplies necessary maintenance for critical utility system that delivers ventilation and water to the patient care areas. IP provides essential input into preventing hazard risk to patients, healthcare professionals, and visitors during design and construction project. The IP will ensure compliance with various compliant regulatory standards and guideline setting agencies. The IP is responsible for facilitating the transport and approval for disposal of waste materials. Which option do you think is the correct? Please comment in the comment box. Excellent. So the correct answer is yes. Answer is B. The IP provides essential inputs into preventing hazard risk to patients, healthcare workers, and visitors during design and construction projects. Question number 2. Poor planning during a construction project can lead to an increased risk of infection related to construction delays, compromised air quality, contaminated water, increase in construction related traffic. Which combination do you think is the answer?
أثناء الركوب آداب الركوب أو أثناء الركوب إحنا نسميه أثناء الركوب.
Okay, perfect. Hello, can you hear me?
Yes, we can hear you, Ms.
Okay. Okay, so the answer is option C, yes. So question number 3. So a healthcare facility is undergoing extensive renovation. Surveillance for which of the following organism would be particularly important during any construction renovation project in a healthcare facility? Is it MRSA, VRE, and other MDROs? Is it Legionella and Aspergillus? Is it gram-negative bacteria or Mycobacterium abscessus? I know the answer is very, very easy. Yes, you need to be very careful with Legionella and Aspergillosis. So we are almost end of the session. These are my references. I can share the slides if you want. And if you have any questions, we can discuss it now. You can unmute yourself and ask your question. If not, you can even check put your questions in the chat box. Yeah, sure, I will share the slides. Over to you, Anu.
Thank you so much, Ms. Lakshmi. It was a wonderful session. And thank you all the attendees. Now, I would like to request you all do our one questionnaire. It will be shared shortly. So please do it. Evaluation form link has been shared already. Kindly do it, please. Thank you. Hello, all attendees. Those who have done their evaluation, they may leave the meeting. Thank you for joining with us. Thank you so much.